Good morning, everyone. I'm Kathleen Warshawsky, and we are here today to talk about the challenges of hospice care during a pandemic. Our guest speaker today is Ms. Jennifer Broadway. She is a registered nurse and the administrator of hospice with CC Young Senior Living. Welcome, Jennifer.
Thank you. Thank you guys for joining us today.
Yeah, we appreciate that. The purpose of today's activity is to promote an improved understanding of the registered nurse, social worker, and other healthcare providers on the challenges of hospice care during a pandemic to help promote the quality of care at the end of life. Our learning goals include identifying safety protocols for staff, facilities, patients, and families during COVID-19, to describe the challenges of hospice care in both the home and the facility settings during a pandemic, as well as to understand how to satisfy the conditions of participation in a virtual environment. In order to receive your educational contact hours for today, you have to, one, register for the event via the webinar, which is Zoom, attend the full presentation. There's an evaluation tool that will pop up on your screen at the end. You must complete that evaluation tool. It has to be done within 24 hours of today's event. If for any reason you don't receive it, please email me immediately and I will send it to you via email. Once we've verified that you have met all of the criteria, you will be emailed a certificate of completion, and that will be sent to you sometime next week. Conflicts of interest for today's event, there are none, and there's no sponsorship or commercial support. Today's activity is brought to you by Seniors Blue Book, CareWorks, and CC Young Senior Living. I want to especially thank Jen Griffin with CC Young Senior Living to help me coordinate today's program, as well as our speaker, Jennifer. And Jennifer, do you want to take it from here?
All right, I will take it from here. Good afternoon, everyone, and welcome. Just wanted to talk a little bit about the challenges that hospice companies are facing during this pandemic and the best ways to provide care, maybe some helpful tips and ideas on how to care for your patients, as well as some regulations and guidelines from the CDC and from CM. Next slide. All right, our learning objectives today. The first one will be learning about safety protocols for staff, for facilities, for patients, and for families, and in whatever environment that we're providing hospice care. We're also going to learn how to satisfy the conditions of participation in this virtual environment that we are in due to this pandemic. Okay, next slide. Just kind of a reiteration of what I just stated. Again, I'm the hospice administrator for CC Young, and I've been in hospice almost 10 years. I've been a nurse for about 25, and done a little bit of everything. But that brought me to hospice, where I will stay for the rest of my career. All right, next slide. Let's get down to business. Okay, on here I put a link for the CDC for guidelines for healthcare workers. And you guys can copy that down or click on it, and it goes straight to the CDC site where it talks about guidance for risk assessment and work restrictions for healthcare personnel with potential exposure to COVID-19. There are several different tabs on this site that talk about specifics like infection control and testing and all that type of thing. Most of it is aimed at long-term care facilities that are caring for this at-risk population. but some of it does pertain to us since we are taking care of people in those settings. Next slide. Okay, when you go to that site and it talks about infection control, it has two different points. One of them is the recommended routine infection prevention and control practices during the COVID-19 pandemic. And those type of things, I also have the link there again on that page. But that is your basic infection control, which we all know working in healthcare. But it also has some additional practices that include implementing telehealth and triage protocols during this. We all know CMS has changed some of their guidelines on allowing the telehealth visits and face-to-faces and such. So implementing that as often as possible and when feasible to reduce exposure. It also involves screening and triage for everyone entering a building, a facility, a home. That includes employees, visitors, guests, whoever might be coming in and out. I'm sure you guys are all used to being screened if you're entering your place of work. So that's taking the questionnaire on if you've been exposed to anyone, if you've traveled, if you have any symptoms, and that type of thing. It also involves proper hand washing, limiting the amount of guests, screening stations outside of facilities. You see it in doctor's offices. You can see it at different stores around the place. So it doesn't only stop at when you enter a facility, but if you have hospice patients in a long-term care facility, they're also monitoring their patients daily, checking their temperatures and making sure they're asymptomatic. So that's an ongoing process. Also involves, social distancing, which we're all getting used to these days. Let's see. The second point on this is the recommended infection prevention and control practices when caring for a patient with suspected or confirmed COVID-19. So if you happen to bring a patient in from a hospital and maybe they tested negative before they discharged, and they become symptomatic when they're on your services, just the different protocols and recommendations to do, again, to protect yourself and protect your teammates and protect healthcare workers in the facility. Again, it's your infection control, it's wearing the proper PPE to take care of that patient, and continuous monitoring if they are symptomatic. That involves testing them for COVID-19 and that type of thing. Obviously, proper hand hygiene is what is recommended, and communication with your team and teammates. If you have any patients that are suspected of having COVID-19 or they have symptoms, to make sure you communicate that well with everyone. The proper PPE, there is preferred PPE when you have a suspected case, and there's also acceptable. So if you will click to that next screen for me, please. Okay, the preferred is the N95 mask, which I would suggest if you have any patients coming out of a hospital or out of a high-risk environment. Also, a face shield or goggles to protect your eyes, proper gloves, and an isolation gown. That way you go in with that proper equipment. When you're done, dispose of the gloves and the gown and the mask, and can do that every time you go into that patient's room. There's also acceptable PPE, which most of us are wearing the mask anyway when we're in any kind of close contact with our patients, but it's any type of face mask, face shield or goggles, gloves, and a gown again, especially if they have any type of symptoms. And let's see. So with the PPE, it also means you need to train your staff. You need to make sure everybody knows how to wear the appropriate PPE, how to put it on, and that they also have to the proper supplies with them, especially your on-call staff, just in case they get a call and need to go into a situation. Make sure that they all have that with them at all times. All right. Any questions on that?
If you have any questions, please do type them into either the Q&A or into the chat. Everyone's very quiet this morning. I've been watching. So I do have a question while everyone else is thinking about whether or not they have a question. So I know that the ideal use for your N95s, et cetera, is one-time use, and you change it after each patient and all of that. And as we know, that's not really happening right now. So what are you seeing in the field out there today? How many times are nurses being asked to reuse their PPE in the clinical setting, in home care and hospice right now?
I would say at first, when this all happened back in March, all the PPE was very scarce and hard to get our hands on. So I know that long-term care facilities, I know some of the facilities that I've heard about, they didn't even have masks for their nurses taking care of these patients, and they had large outbreaks. So I know in facilities that were able to get the N95s in a limited supply, they were, wearing it all day, maybe several days in a row until they could get their next one. I know some places that had the little UV light that sterilizes masks that they tried, but I think at this point everything is readily available for most home health and hospices and facilities. So I know we have a stock at CC Young, so we're very blessed and fortunate to be able to access what we need to take care of these patients. But we wear the N95s for our like on our SNF, where the patients are just coming out of the hospital, even though they've been tested, they still could develop symptoms. So they're in a quarantine for 14 days and retested. That's our protocol before they're able to come out of quarantine, which means you don't have to wear all the PPE as if they had it. Still wearing the mask and gloves going in. But on our other floors is our long-term care. We're just wearing face masks. And if a patient does become symptomatic, fever, cough, shortness of breath, things like that, then we put them back into quarantine, isolation, wear the N95 there. So does that answer your question, Kathleen?
It partially answered it, I guess. So currently today, if let's say I'm working with one of your COVID positive patients, would you be asking me to wear my N95 for the full day or for the week, or like how much supply do people have, I guess is the question. Because in the past, I'll just say 2 years ago, if I was in the hospital setting, I would be taking it off, discarding it, and putting on a new one probably 15 times a day or 15 times a shift.
Right. And now I would say if we don't have any, in our facility or in our hospice team, we don't have any positive patients. So we've been very fortunate in that. If we did have one, that would be, you go in, use it, dispose of it, so then you would get another one.
Okay.
But, and I guess in general practice, like if we do have home patients or facility patients, ideally you just wear it into that facility and then dispose of it afterwards, to get a new one.
Okay, perfect. Thank you so much.
Okay, you're welcome. All right, we will go on to the second learning objective now. If you'll flip to the next slide, please. Okay, and this is maintaining our conditions of participation during this pandemic when everything's shut down or people aren't letting you in their homes, or maybe a facility that has positive cases and you're unable to go in to care for your patients. So this is about virtual visits, telehealth, virtual IDT, and virtual face-to-faces, and recertifications and that type of thing. So, all right, the next slide is, can we satisfy the conditions of participation with virtual visits, and that answer is yes. CMS has lightened their regulations so that we are able to provide hospice care virtually with voice and audio visits. And it's to help all of us continue to take care of those in need, even though we might not be able to go visit them. So let me... on my notes here. So the telehealth visits, they are a little bit more relaxed from the strict guidelines before, but they're still to be secure and exercise discretion, and we won't receive penalties for any HIPAA rules that might be a little bit gray during this time. So for us that are able to do telehealth visits, we're able to, a healthcare provider can use any non-public facing remote communication product that's available to communicate with patients. So iPhone, a tablet, computer, I don't know if there'd be much else to use, but the applications that are allowed, FaceTime with your iPhone, Facebook Messenger video, Google Hangouts, Skype, Zoom, things like that. Things that are not allowed are like TikTok, Twitch, Facebook Live, things like that that allow public interfacing.
So Jennifer, I have a question on that. So your virtual visits don't have to be encrypted currently?
Not currently.
Okay.
There won't be any penalties for that. It's the requirement is video and audio, so they won't allow a telehealth visit with a doctor or a nurse visit with just audio. You actually have to have video, so they have less than the requirements. You're able to use probably FaceTime is the easiest one from it.
Okay, thank you.
You're welcome. Okay. And let's, telehealth visits are what we're doing with a lot of our patients in facilities. Sometimes it's hard to track people down in the facilities. They might be shorthanded, or they might have staff out and just not able to coordinate times. We've done the best we can with our patients in facilities that we're not able to go into unless a patient is transitioning or imminent. So we work with our marketers that have good relationships there to schedule the conference calls as best we can, and the nurse catches the nurse that's on the floor going to do the FaceTime and actually get vital signs and get report on how the patient's doing. So that is kind of how we're handling things. Our social worker isn't really allowed to go anywhere except, our home patients and that type of thing. And the same with the chaplain, but the social worker is able to make phone calls, and those are still billable just like they were before COVID-19 visits. And the chaplain, they can do FaceTime, phone calls. They're seeing our home patients, but in the facilities, they're just calling in to the DON or the nurse or social worker there and checking on how things are going and if they need any support or anything from us at that time. So there are some different rules for the disciplines.
We have a question. Do you want to take it now or a little bit later?
You can go ahead and take it.
Okay. So this is from Pauline Yarborough, and she would like to know, Do you do patient and family discharge teaching on COVID prevention?
Well, we do on admission and patients that were already out service. We do that teaching, and there's some good information on the CDC and on CMS, just on infection control, hand washing, reporting symptoms before we go out to see patients. The discipline will call and ask them. We have a little questionnaire that we fill out on the traveling and if they've been exposed type of thing. So you screen them prior to going to visit the home patients. In facilities, they screen us prior to us coming in. And then as far as our own team, we have, our daily temperature checks. So if they're not coming into our facility, they're checking their temperature and sending it in and answering our questions daily. But for the families, we try to make sure they know about social distancing and about not having a bunch of people come and visit and that type of thing. So that can be a challenge for the home patients as well that want to get out and do.
Great, thank you for answering that.
Sure. All right. You can flip to slide. Okay, this one is pretty easy and straightforward. Virtual IDT. The regulations say that hospice IDT must review, revise, and document the individualized plan as frequently as the patient's condition requires, but no less than every 15 days. So the regulation does not state we have to all meet in person together. So, of course, that's ideal under other circumstances, but kind of where we are today, if we have people on this, we do meet in a conference room. We are 6 feet apart. We limit the number of our team that is in there, and our physician calls in. Whoever's off campus, call into our conference line, and that way we can have our IDT. And if things come up in between our IDT and we need to conference with about a certain patient with a family member and the doctor or the whole team, again, we found a conference line that we can call into, kind of like Zoom, and that way we can discuss it virtually, and we don't have to risk any more exposure than we need to.
Jennifer, can you explain what IDT is?
Yes, that's our interdisciplinary team, and that involves our medical director, it's our physician on our team. It is our RN case manager that's on the team. There's a DON as well, our social worker, our chaplain, our volunteer coordinator. What am I leaving out? And if the aide has DNA, if they have any input, they join the team. Sometimes we have our CNAs kind of, in certain situations these days, they're the ones seeing the patient the most, and like independent living and such. So they're very key point of contact. And then we discuss every single one of our patients every 14 days. So that's the whole thing where we talk about their frequencies. Are we meeting their needs with how many times out? Are their medications helping whatever symptoms they might be having? Do we need any new orders? Do we need to change any of their care plan? And things like that. So we discuss that if they have skin breakdown or if they've developed an infection and all that type of thing. So that is our interdisciplinary team.
Thank you so much.
You're welcome. Thanks for asking that.
Yes, sometimes y'all are used to having some lingo that not everyone understands, and so.
Exactly. So I was gonna give kind of a case example that I have here about a terminally ill 85-year-old male patient. He has heart failure. He's been receiving hospice services. He's recently developed a fever, a sore throat, and cough. He's been diagnosed with suspected COVID-19, and his hospice plan of care now includes medications for symptom management of that. He's mildly short of breath, but he doesn't need supportive oxygen therapy. His wife is concerned about potential for worsening his congestive heart failure and his respiratory symptoms as a result of the patient's risk for complications due to COVID-19. So the hospice team would develop the plan of care and update it to include remote patient monitoring with a telecommunication system like FaceTime or Facebook Messenger. The plan of care identifies the measurable goal that the patient will maintain an oxygen level above 92%, and the patient will not gain more than 2 pounds in a 24-hour period of fluid due to congestive heart failure. The plan of care identifies interventions if either of these goals are not met. So if the oxygen saturations go below 92, to initiate oxygen therapy and that type of thing, and notify the physician. The remote patient monitoring allows for more expedited modifications to the plan of care in response to the patient's changing needs. So there's some good lingo that we've implemented on our team when we do these televisits to make sure that we document, because that is key on that type of thing, which means that we would indicate in our plan of care that we are doing a virtual visit, and that it depends by discipline on how they're communicating, if it is FaceTime by a nurse practitioner or physician, or just perhaps by phone call from the social worker. And so you want to make sure that the televisits are tied to the patient-specific needs identified in the comprehensive assessment. So you want to make sure that visit, if they're having shortness of breath or symptoms of that visit indicates that. And then describe how you use your technology as well in your documentation. So for example, I have a telehealth visit for this patient to protect patient and caregivers from illness due to the pandemic, the national state of emergency, and perhaps shortage of nurses. If that is the case, if you have some nurses that are sick and unable to work, then you would say you spoke to the patient and the patient's wife via FaceTime, and that the patient is maybe non-responsive or grimacing or visibly short of breath over the video feed. And then, what you did, if you needed to dispatch a nurse out, or if you just to change your medication, and then document follow-up and communication with your team at the same time. Do you have any other samples? And this time too, I know some hospices and some facilities have actual employees that have COVID-19, so they're unable to work until they're clear of that. So CMS has also relaxed the guidelines on that you can contract with core services if you don't have enough nurses, which is a core service hospice, as well as social worker and chaplain. And if you do not have them, you're able to contract with a company that has them to help provide care, or even contract with another hospice agency that might have nurses that you need, and maybe their census is low. So you are able to do that to fill those positions temporarily to care for these patients. So that is another change we have. Let's see. Anyone have questions on that so far?
So one of the questions that we have, that you may have covered it already, but I don't need the answer to it. I'm not sure that we covered it. But what is happening if families don't want to let you come into their homes, or if a family or a patient is in an inpatient for example, in a SNF or an assisted living, and the facility won't let you come in as the hospice agency. How are you handling those types of things, and are those things even happening?
Yes, they are. I would say the majority of facilities, even assisted living facilities, which are not long-term care, they're not regulated by CMS like the long-term care is, where they said only core essential employees can come in and compassionate care employees. They're all on lockdown. Perhaps they have some COVID-19 positive residents or employees. So they are very tough to get into. We have a facility that allows us in. They do compassionate care essential, which that is their order that is currently in place. Some facilities consider compassionate care. They say, we can take care of this patient unless they're imminent. We don't need hospice in here. So, of course, we're partners with these places, so we don't want to get in an argument with them. But the ones that allow us in, we appreciate that. The ones that don't and want us to only come in if the patient is imminent, we have to implement the telehealth visits. If we have a patient at home that says, I don't want anybody to come, then that's when we try to implement the telehealth. If they don't have a phone or a way to communicate audio and visually for that telehealth visit, we have to just document why and to the best that we can, and try to educate the family and the patient on our infection control measures and what we would do to try to get in there. If they don't have any way to communicate, we can also try to get them a tablet or some sort of phone or something where they can use that to FaceTime with us. But those are tough. So CMS does recognize that. Again, the social worker can call, and that is a billable visit, but for the other disciplines, they're unable to do the the virtual visit, then those visits are not billable. But we haven't come into a situation like that yet, so I don't know. I'm sure some other people have. We've just come across it in assisted living and long-term care facilities so far.
Okay.
And there's some other services that CMS has changed their regulations on that as well. Like volunteers, they're not requiring the 5% right now, so that's a relief of hospices, because our volunteers we don't need to put people at risk of exposure for them going in to visit people, as well as the hospice item set data. Submitting that, Medicare will penalize a company if they don't submit it timely, and they will take off 2% of their reimbursement. And they're waiving that right now for the first and second quarters of this year. That they're waiving the timeline on that, so they won't be enforcing the 2% penalty for this. So that's a little relief for us as well, especially with some people that maybe are short-staffed in their office. So.
Excellent. Now, for the facilities that are not allowing hospice to come in, are any of them choosing to take their loved ones home and have you follow up with them at home? Or how is that working? Or are they just not receiving the full benefit of hospice?
For the ones, we've had some families that, I don't want to say threatened, but said, well, I'll just take dad home, and which they are completely allowed to do. We try to make sure that they know the risk and benefit of that, where if they might not be getting visits from their family and from all the disciplines in hospice if they're in a facility not allowing anyone in, but they're protected because all the staff is screened and every discipline that enters that facility is screened, and all right now the long-term care residents have been tested as well as the employees. So we try to make sure families know that, because when they bring a patient home, if you have somebody that's still working or grandkids in the home and different things like that, they're going to be at a much higher risk of contracting COVID-19 if there's a lot of people in and out of the home. So we actually had a patient and his wife move from an assisted living to their home. They had moved from their home to assisted living and really just wanted to go back home. And they did, but they didn't have caregivers and they didn't have people keeping an eye on them like they did in assisted living. And they're needing a lot more help than they thought they would. So there is some risk, to moving home, even though they do get to see their families. Kind of on the flip side, the residents we have that have stayed in the facilities and not been allowed to see their loved ones, whether that's their spouse or their children or grandchildren, we have seen a decline in a lot of those patients from not getting that emotional support from them. We actually, our protocol for us is if we do see a patient transitioning to imminent, which means we think that they are starting the dying process and might only be with us for 3 days, say, we do notify the family. We meet them at the door of our facility and we escort them up with all the proper PPE to their loved one's room, and that way they can visit, and then we escort them down when they're ready to leave. We have had actually 2 hospice patients that we believe were imminent with a sudden change. We had their family come visit with them, and it was almost like a miracle. They turned around, and that was weeks ago, and they're both still here, and they're kind of back to their normal before that happened. So we wonder, was it because they got to see their family, or just felt that support and love that they really did have that. So we have seen, sadly, a lot of decline in our patients and residents from being isolated really from their family and friends.
Understandable. Are you all able to do any pet therapy right now?
No, we're not. Our pet therapy are the volunteers, and they're non-core services, so they're not allowed into any of our long-term care facilities, and we're not utilizing our volunteers now just to decrease risk. We wouldn't want to expose any of our patients to that, so not currently.
Okay. And then are you all currently taking COVID positive patients to your hospice service?
We are not. We have not had any actual referrals that are COVID positive. So I don't know of any other hospices out there. From the ones I've spoken with and communicate with, they haven't had any either. I'm sure there's some out there. I don't know if they're staying inpatient. I do know a lot of the people that contracted and become terminal, they stayed in the hospital, and I know families haven't been able to see them up until recently. So I don't know if that's the case for anyone else out there if they're staying in the hospital. I know as far as our SNF is concerned, we've received some recovered COVID-19, so they had it, were in the hospital and recovered from it, and don't need hospice. So that's a good thing, but we have not received any.
Okay. We have another question. Angel from Bader House is asking, we've been on lockdown and our folks on hospice have been doing televisits and it's been working. As we look ahead with the hope that folks other than staff will be permitted back in the residence at some point, we're having a hard time finding a hospice company that is doing any kind of regular testing of their employees to know for sure if they're infected versus relying on just being asymptomatic. We regularly test our staff and residents and have remained COVID-free. Do you know of a hospice company taking that same precaution?
As a matter of fact, we are at CCM. I actually test our employees, and we're part of a larger picture. So we have, independent living, assisted living, but we also have the SNF and our long-term care, which, by the state, they had to test all the residents, all the employees. So, and that includes us because we're on those floors with our hospice patients. But before that happened, even back to March, we were testing employees. So we screen if they've been exposed, if they have a fever, if they live with somebody that was exposed. We're very, very cautious, taking very many calls to try to reduce that risk. So, for example, we had a hospice employee that had a child that played with the next door neighbor's child, and that child's mother actually was positive for COVID. So she had to stay quarantined. And once her quarantine was up, I tested her, sent it in, it came back negative. She would come back to work. So all of our teammates are aware that even if, they're taking as many precautions as they can, online grocery pickup, that kind of thing. But if they know of any way they've been exposed, or if they just don't feel good, maybe they have a cough, fever, we make sure they quarantine, then we test them, and they have to come back negative before they get back to work. So we are doing that with our employees. I'm not aware of many other hospices testing their employees because, it's not right now. So it's kind of hard to get your hands on the test. Fortunately for us, being part of this bigger picture, we have a couple labs that we work with, and they, like this week, they sent us about 100 tests. So we're able to get a lot of the bits in. We test them, we overnight them to the lab, and we get results within about 48 to 72 hours. The last couple of weeks, it's been a little bit longer because of the increased amount of testing in the state, but we're doing that, especially if anyone's symptomatic. Some of our employees that go into other facilities that are still allowing us in, they are requiring that we show them a negative test. So we're having to test that way as well to make sure they know we're, doing our due diligence.
Okay, great. Do we have any other questions right now? If you do, just you can even just put something in the chat or in the Q&A, and then I can give you the opportunity to talk if it's a long question.
And kind of along the same lines with that question, as far as like an initial referral to hospice during this time, that just reminded me like of an admission. We've been lucky enough to be able to go do our initial assessments on all of our new patients that we've had to hospice, but I know there are some cases in some facilities, that work several referrals, they got quiet when we asked them, do you not have any patients declining that need hospice? And a couple of them say, oh no, we can take care of it until things open back up where you can come in. But we are able to do a telehealth admission assessment if that's what's needed, as long as we can see them over the phone, ask them all our questions, and as long as they have a caregiver or a nurse or somebody there with them that can help us through the assessment. And we can meet their needs. Now, if they're critical or very symptomatic, that's going to need a person-to-person visit. But if it's maybe earlier in the disease process and they are terminal and need hospice, we can do that admission assessment over the phone. We can do our comprehensive assessments. They were required by Medicare for the RN to do every 14 days, but they have less than that requirement as well. So we can do that every 21 days, that comprehensive as well. So there are some workarounds if there is a patient needing hospice and they're in a facility that, they're not letting anyone come in. We can do the telehealth.
Okay, awesome. Thank you so much. I appreciate that.
You're welcome.
Do you have any final words for us that you want to share?
Be safe out there. If you have any questions, please feel free to call. I have the main number on there. I also put my email. It's easy, jbroadway@ccn.org. I'm happy to help in any way I can. I think that is it. I appreciate you guys.
Thank you so much. We appreciate you, Jennifer, as well. I just want to make sure that all of you know that Seniors Blue Book is available for your patients and for your residents and your clients. We also have our Discharge Planner Resource Notebook. Both of them are available in print edition and digital format. So if you would like a digital copy, please let me know. If you need print copies, you can just shoot me an email with the address and the number that you need, and I will either deliver them to you, obviously just leaving them for you, social distance style, or I will mail them to you. So let me know if you need those as well. And I want to share with you, in our discharge planner, we do include the conditions of participation for discharge, and we also include the out-of-hospital DNR form for Texas. And I want to thank you all for joining us. I want to thank CC Young Senior Living and Jennifer Broadway for sharing in this presentation today, and for sharing knowledge with us in this difficult time. And I want to thank you all for your support and for joining us. I'm Kathleen Warshawsky with Seniors Blue Book, and your certificates will be sent to you. Watch for the survey that's going to pop up on your screen, and just shoot me an email if you need anything. Thank you so much. Have a great day. Stop.